slides. So,
Yes.
good afternoon. My name's Jonathan Downie. I'm a consultant in paediatric palliative medicine in the Children's Hospital in Glasgow. So I know a few of you, so it's nice to see some familiar faces or hear some familiar voices, and nice to meet some new people too. So what we're going to talk about today is really trying to equip ourselves with a communication toolkit. To kind of look at how we have goals of care conversations with families, how we are best able to advise families from a myriad of medical options or complex decision making based upon what we know is important to them as a family. And I think this is something that we do daily in our jobs, but it's something that I'm not sure that we always get right in terms of hearing a family's voice through that. So in terms of our objectives for this session, I thought it would be useful for us to kind of understand the value, so how important it is to have goals of care discussion with children who've got advanced illness. Think about why communication can be so hard. Some of the fundamental goals, I'm going to give you some tips as to how to have these conversations, and then let's think about language that either disrupts or facilitates these conversations. And then we'll consider what happens when things go wrong, because that often happens. So I'm not sure if any of you have heard of this man. His name is Eric Cassell. He was a professor of public health in Cornell University in New York. And he wrote extensively about human suffering and how ill-equipped our healthcare services are really to deal with suffering in its holistic form. And when he spoke about communication and why it was important, and he compared it to, so he said, similar to scalpels for surgeons, words are a clinician's greatest tool. And so surgeons learn to use their tools with extreme precision because any error can be devastating. So too should clinicians who rely on words. And I guess at the start of this, I want to say that, I think often we feel that communication is something that we inherently have or don't have, that people are good at it or they're not good at it. It's seen as a kind of fluffier side, an additional extra sometimes to what we do, but actually the reality is it's critical to what we do. And often actually when things go wrong or where there is disagreement, it often boils down to a failure in communication or a breakdown in communication. So I want you to think about, now it's difficult to do this interactively, but I want you to think about individually whether you think education and training and communication is important, and you perhaps can write that in the chat, whether you think it is important. And then the second question is actually most importantly, who's received communication training, either rather than just being directly observed by consultants that you work with or senior trainees that you work with, have you actually received communication training as an undergraduate and as a postgraduate? So if you can put that in the chat, because it's just quite interesting to know actually the baseline in which people actually get education about communication. And I'm going to continue talking while you do that. So if we think about what the value of having a goals of care discussion in children who've got advanced illness, so that incorporates children who've got a malignancy. So if we think about this idea of parallel planning, so often we think about curative or disease-directed therapy, and there's this line in the sand, and we are entering into palliation. And I think what we now know is that actually there is no line in the sand. That line is very blurred, if there is any line at all, and actually we need to navigate that very, very carefully. So parallel planning is when we plan for life, but we're also accepting that there is a possibility of deterioration and or death. So if you think about children certainly who have high risk malignant cancer diagnoses, they would fall into this category. And why is it important? Because it enables families and professionals to consider and plan for various different options and a range of potential outcomes. So that will include treatment options and interventions that will prolong life. But it also allows us to reflect on what would be important to a child and their family if life extension is no longer an option. And actually what that helps to do is empower a patient and families to be able to have choices in the worst case scenario. And the reason that it's important to initiate this from almost the beginning of a diagnosis that we know is likely to be very serious and likely to limit life is that it allows this blended approach. So this role of palliative care as a philosophy of care rather than just being at the end of life from the very beginning. And so at the beginning of that, the emphasis will be on cure or life-prolonging intervention. And actually, as we move more towards deterioration and end of life, then the emphasis is more on preparing for that. But actually, those two things are not mutually exclusive and they can sit hand in hand with each other. And that's important because it allows us to consider curative options, but it also allows us to look at symptom-orientated management. And that's really important because the research shows us that parents don't view these things as mutually exclusive. It allows families to receive support and preparation for future outcomes, and it allows families to be able to prepare for goals. And see, if that doesn't happen, what we have is this emphasis on cure, life-prolonging treatment, and then bang, we get to a point where everything changes, there's no time to plan, there's missed opportunities in terms of conversations and also in facilitating, family choices. And often people are left with a sense of failure. And that can be true of both clinical staff, but also in terms of families when they look back on things. I want to share with you, it's easy for me to say this, but I want to share some words of families that have looked after their children. So it was futile, but the doctors couldn't speak to us about a palliative care approach. There was no end-of-life plan, no DNR. We wanted that, but we didn't have the strength to jump up and down asking for it. Nobody would make the decision that enough was enough, and it didn't seem how he died mattered. Now, I don't think that anybody goes into medicine to ignore parental wishes, but I think the point of this quote is that often we think that we're protecting families from difficult conversations because they're not ready yet, or actually we feel it would be too overwhelming for them. But I guess what I want to say to you is that families often have these thoughts, and they often hold this internally, but they don't have the energy or the strength, or sometimes the desire to be able to talk it out loud. And sometimes by you opening that and by broaching these conversations, you give them permission to talk about things that they are really worried about. It's good for us as professionals as well because it gives us a sense of security and control, and we like that as doctors. It clarifies goals of care, it gives us very clear instructions about how we're going to manage certain scenarios, and it allows us to prepare for the future. We know that it actually improves the quality of your care, and it also respects patient autonomy. So is advanced care planning or parallel planning or having goals of care conversations, is it actually something that parents and families find helpful? Because it might be helpful for us, but if it doesn't help the people that we're here to serve, then is there really any merit or value in it? And so actually what we know is that for families, these conversations are not just about withholding treatment or resuscitation status, as they often are for us. They're about an ongoing conversation. So actually, these are not one-time conversations. These are conversations that occur throughout a child's illness trajectory, and they make very fluid plans that can change. We know that families, that even though the topic of their child's death is incredibly, emotive and sad, the majority of parents find these conversations very helpful because it helps to ensure the best care for their child, and that includes preserving their quality of life and avoiding unnecessary suffering. We know that families are more likely to make informed choices about end-of-life care if actually they've had some involvement in the decision-making about the planning for deterioration and end-of-life. Interestingly, I think adolescents are a population that we often try to protect even more so than we do sometimes parents. This is a really interesting study that looked at young adults and adolescents with brain tumours, and their thoughts on palliative care and having discussions with their disease-directed teams, so their oncologists, about end-of-life care. And what it showed was actually they wanted to have those conversations, but they often felt that those conversations happened late. And actually that we shouldn't be frightened to broach these topics because actually these are things that they've thought of. And often actually what they are worried about is far worse than what we potentially are worried about. It's about opening up and having more transparency. So we know that by actually having informed parents or families or young adults, that they contribute better to management decisions. They're more likely to work collaboratively. And actually when things change, as they often do, and so we know that that happens in the malignant population, that things change in terms of relapse, people are refractory disease, you have progression on treatment, that actually when these things happen and the goals of care change, they're more likely to come with you. So what is so hard about communicating? So I want to share with you, I want you to reflect on the answers to the questions that we asked initially. I want you to think about, this was a study that was done in North America amongst paediatric trainees and clinicians, but these are trainees who worked specifically with him in hemato-oncology and bone marrow transplant. And we know that 85% of trainees receive some training in handling difficult communication. But actually their confidence in their ability to handle difficult communication was low. And they specifically found it difficult talking about withdrawal of life-sustaining treatment, how you talk about SPADM forms or resuscitation forms, and actually their ability to lead a team to debrief following the death of a child. And I guess in my own experience, I mean, I'm a relatively new consultant, I think that the majority of my communication was learned by watching other people. And whilst there is huge merit in that, there comes a time where you then are handed the baton to have that conversation, and that can be very challenging the first time that you're doing that as a brand new consultant. So I think opportunity to practice this is really, really important. It's interesting when we look at the barriers to communication. So you think about what we think about difficult conversations. So if paediatric oncologists were asked, what is the greatest barrier to difficult conversations? And what they came back with were things related to families. So unrealistic expectations, a family's denial, family conflicts. It might be a patient's unrealistic expectation or denial. And I guess what I want you to reflect upon is, when we say that we have difficult communication as doctors and as healthcare professionals, what we often mean is that a family is difficult, or that we're finding a family pretty tricky. And this is a really nice study that was done again in Boston, and they looked at, in Dana-Farber, and what they looked at was paediatric care conferences of children with cancer, and who talked the most. And it'll probably be unsurprising to you that actually it was clinicians that talked the most, about 75% of the time. And parents or families talked for about 25% of the time. And then they looked at the content of those conversations, and about 80% of it was about medical conversation. And only 20% of it really reflected on a family's individual values or preferences. And so what we know is that family satisfaction is inversely related to the time that a physician speaks. So for those of you who have seen the musical Hamilton, that quote, "Talk less, smile," is actually quite important. So I guess what I'm trying to say to you and challenge you is that sometimes as clinicians, when we talk about difficult conversations and how, we are challenged, to respond to that, and it really is about families, I want you to think that actually, is it really, or is it that we're not listening to families or affording them the opportunity to speak? Because why is it we blame the people who speak the less and the least in these conversations? So again, this just reflects some more of the barriers to conducive advanced care planning. Again, lots about unrealistic expectations, differences between clinicians and parents, understanding of prognosis or disease trajectory, and a lack of parent readiness to have that discussion. I guess one of the things that I want to challenge you are that I hear that all the time, well, the family are not ready to meet you, Johnny. The family are not ready to talk about palliation. And I think sometimes what that actually means is we're not ready as a clinical team to start having those conversations. Because as I said to you, and as that quote showed to you earlier on, families often have these thoughts and have already thought about these things well before we have. So we know that advanced care planning is important. So an ACP is typically made between you and your medical team to help you understand the best way to care for your child and fulfill your wishes in the event of an acute illness or sudden deterioration of your child's condition. So this was the definition that families were given about an anticipated care plan. And then they were asked, actually, how important is it for you as a family that we have these conversations? And you can see from the results of this paper that actually they are very, very important. I think this is also very interesting because this study then went on to look at, okay, so when should we have these conversations and who should be leading on these conversations? And so really interestingly, at the moment, if I was to ask you when we have these conversations, I'm pretty sure that the majority of you would come back and say when it becomes absolutely crystal clear that the child is dying or is actively dying, that we start thinking, if not maybe slightly before that. But I think we often have these conversations pretty late. And when you look at what families want, actually, they're saying to us, some of them want to have these conversations at diagnosis or realization of this serious illness. A lot of families want us to have it after the diagnosis, but before their condition has deteriorated. So actually allowing them some time to come to terms with how serious their kid's illness is, but actually having these conversations and an opportunity to think about these things before they're actually in a situation where their child is unwell. And much less in the way of actually let's have these conversations where it's clear that they're not going to survive and no family wants to have them when death is imminent. And I think when I want to challenge you about who has these conversations, because often I think people now are saying, well, we've now got a palliative care team, so really is it the palliative care team's role to come and have all of these conversations? And I think what you see from this section here is that's actually not the case. In fact, actually, we're the people who families least want to have conversations with. They want to have these conversations with people who are either leading on the care of their child, so the disease-directed team, or actually within the intensive care unit. And I think that probably reflects the complexity of care of the children that we look after. Okay, so what are some of our professional difficulties and barriers to having these conversations? So I think it's true that, we all come into medicine because we want to make people better. We want to be able to offer interventions and therapies that prolong or provide cure. So we want to be positive and we want to help families get through treatment. Often we say, well, it's not really happening yet, so we don't really need to have this conversation now. Another thing that you see quite often when you're split between a tertiary hospital and a district general is that the specialist will say, well, we really only see this family every 6 months. So it's really for the local providers to have those conversations. And local teams will say, well, we're actually not the disease experts. So actually it's important that they hear it from the experts and not from us. And the reality is that we need a blended collaborative approach to have these conversations in a way of documenting so that it's really clear what conversations have been had and what's important to a family. The other thing is that families come to us with this expectation of cure, so that's where we need to be focused. We could speak all day about hope, parental hope, and how important that is to help you survive dark times, but how it also influences decision making. And this idea that parents will think that we're giving up. So we're going to come back to some of these things. Often we are disease focused rather than patient focused. And I think that is true. That's an unintended consequence of the way that medicine has become. Care is becoming so complex. People are surviving for much longer. We are able to provide intervention which extends life beyond probably therapeutic value now. And actually, as a result of that, we often become very entrenched in looking at disease focused care rather than patient focused or family focused care. Why is it difficult for us? And then, we sit with all of these things in our head about why we think the barriers exist and why we don't have these conversations. But I think the reality is we need to give ourselves a bit of slack, because these are huge conversations and it's a huge clinical responsibility to come to a place that there is no more that we can do to cure the child, that we're not going to continue to turn over absolutely every stone, and to tell a family that their child is going to die, what if we get that wrong? Now, we're far less likely to get that wrong in children with malignancy, but we get it wrong quite a lot in kids that don't have malignant diagnosis. It's also incredibly difficult to do. There's a huge emotional burden for us, and especially in hemato-oncology, you have long-standing relationships with these families and children and young adults, and you become invested in their care and a part of their support system. And so there's a real sense of emotional burden, but also the sense of failure. You're letting people down, that you've not done enough, and that we want to retain hope. So, okay, so we're sitting in this territory where we recognise that actually allowing parents and families to have an opportunity to discuss goals of care is important. Okay, no one denies that. And we've shown why that's important, because it allows them to plan for every single eventuality, or be able to discuss their worries and their fears about the different eventualities. And it gives us security as professionals about where we're heading, and actually allows us to change. When goals of care change, it allows us to bring the families with us, recognising that there are barriers on either side of the camp as to how that might happen. So practically, how do we have a goals of care conversation? So I want you to think about Mary. So Mary is a 6-year-old girl who had a central nervous system low-grade glioma. She lives in a rural area with her parents and her 8-year-old sister. Mary was a very upbeat child, and she loved school and her friends. So my question to you is, does Mary need a goals of care discussion? So you can answer in the chat. And if she does need a goals of care conversation, how do we have goals of care conversations? So I'm going to give you my 7-question toolkit as a palliative care consultant about how I initiate goals of care conversations. So the first question that I will ask families is, tell me about your child. And that's not about telling me about your child's illness, that's tell me about them as a person. So what is your child like? What's their personality like? What do they enjoy? What do they not enjoy? For very young children, I might ask about the child's name. What does the name mean? Why did you choose that name? Now, you might think, well, this all just seems a bit, why are we having these conversations? The reality is that sends a really clear signal to this family in the initial moments of meeting them that your interest in them is different from consultations that they've had before, that you're genuinely interested in getting to know their child for who they are. And that's really important for families, that their children are seen as more than just a diagnosis, that they're seen as people. The next question that I'll often ask is, so what's your understanding of your child's illness? And that's the opportunity for them as parents to be able to reflect to you what this journey from diagnosis or before diagnosis to now has been like for them, what their experience of it is. And it also allows you then as a clinician to identify, actually, are we in the same place here? So is the parental understanding the same as the medical understanding? And if not, then how do we work on that? The next question I'll often say to parents is, so what are your hopes? And actually, the majority of parents, when they come back with this, is life extension, a miracle, or a cure. And it's really important that you don't try to remove that, because parents will continue to hope for life extension, a cure, or a miracle right up until their child takes their last breath. And that doesn't mean that they don't understand that their child has got a terminal illness, but those things can sit together. So actually, it's really important. So what I will say to that is just say, you know, that's my hope too. So I'm aligning myself with the family. I really am hoping for that too. But in light of what I know about your child's illness, or in my clinical experience, I'm really worried that we're not going to get that. And actually, my question to you would be, if we're not getting what your heart's desire is, what is the next thing that's most important to you? And start to open that conversation, and you're gently pushing those boundaries. It kind of marries on that if we're talking about hopes, that you also want to know what their fears are. And that's really important, because sometimes what a family's worried about is something really practical that we can immediately, institute. It might be they're worried about, well, what is the future going to look like? What does death look like? What symptoms are they likely to experience, and how are you going to manage them? And actually being able to have that conversation, however difficult that might be, it provides that family with a knowledge and security that you've got this. It's really important that we understand where families get their strength from. So that might be from a spiritual belief, it might be from a religious belief, it might be culturally, it might be from each other. But actually, that's really important, because we're only part of a family's life for a finite period. And then they have to go on in life and be able to live without a medical team round about them. So actually being able to tap them into things that are important and provide strength for them is really important. And then always ask, how is that working for you now? Because what supports us in life at various points isn't necessarily consistent throughout life. So sometimes your support systems are better than others. And the final question is a really practical question about how you're managing day to day. And the reality is that we know that many of our families face not only financial, but food poverty. They, actually transport difficulties. There are practical elements that we can make a lot better by introducing good family supportive care. So by asking these 7 questions, what this will allow you is to get a clear idea about which bucket these families fall into. Okay, so there are 3 buckets that you have after a goals of care conversation. And that is families who want to live, they want their child to live as long as possible, that they want to defer comfort and quality of life, and absolutely aim for curative treatment at all costs. You have other families, and the majority of families, I think, probably fall into this, where they want to live as long as possible, but they also want their child to live as well as possible. So they only want life extension if that life is going to be of quality and of comfort. And then you have the final group, where actually it's not about a long life, it's about comfort, and it's about living for today. And that tends to be much more in a sort of family's mindset when it becomes very clear that their child is at the end of life. So it allows you to be able to delineate these families into these 3 buckets. And why is that important? Because it allows us to be able to advise what interventions might help. So for example, if we want a child to live as long as possible, then actually our assessment is going to be intensive. Our treatment might be intensive, and our follow-up is going to be intensive. If we're looking at a long life, but actually a life that is of quality, then we might say, well, actually, there are certain interventions or investigations or treatment options which would help us to be able to achieve that goal. But actually, do you know what? Going to intensive care and being on a ventilator probably isn't going to allow us to maintain quality of life. So our recommendation to you as a medical team would be that we wouldn't look to do that, but we would do everything up until that point. That's just an example. And so when we talk about comfort and support, actually, that's much more about much more targeted intervention. And it's much more about actually practically how do we maintain comfort rather than trying to extend life. So for Mary, she got zinc and carboplatin, and she got that for a year. She had intensive support from the psychosocial and spiritual teams, and she continued throughout school, and she completed her therapy. At age 16, Mary developed a kind of pain syndrome. So she developed headache, back pain. She had an MRI as part of her evaluation, and it showed it didn't show any evidence of tumour recurrence. But several months later, she presented with spinal cord compression and paralysis, and she was found to have widely metastatic spinal disease. She continued to live with her parents at that time in a rural area. She continued to be passionate about painting. She loved to paint. This is an example of Mary's painting. So what's next? So actually, we've reached a fork in the road, haven't we? Something has changed. So we need to re-goal. So you need to go back to those questions again, have that conversation again. So what are we aiming for now? And so initially for Mary, we were aiming for life extension. And now actually, okay, that goal has changed. So actually we want to live as long as possible. We want to live as well as possible. So what did we do? So we continued cancer-directed therapy. She had an oral agent, but it was really important that she didn't lose her hair. So we had to be careful about what was chosen. Her preferred location of care was home and school. So we avoided unnecessary hospital admissions, and we didn't institute in investigations or interventions or treatment that we thought might cause her to end up in hospital. Her symptoms were managed proactively, so the palliative care team were involved to provide symptomatic support, and she continued to do things that were important to her. She continued to paint. So let's think a little bit about continuing disease-directed therapy. So parents often, these are some studies that you can, I'll share my slides with you, and I'd encourage you to read through these studies, but the headlines are important. So parents often want to leave no stone unturned and do not see cancer-directed therapy and symptom-directed care as mutually exclusive alternative options. So it's not a choice between oncology and palliative care. Actually, parents see these things sitting well together. So our challenge is, how do we work together to be more collaborative? A key factor affecting children's decisions regarding continued cancer therapy at end of life is thinking about their relationship with others and how those might be maintained. So actually you asking a child what's important to them, what their hopes are, what they're trying to achieve is really important to be able to direct you as to even which therapy you potentially would consider. We know that at end of life, the continuing of mild cancer-directed therapy is actually associated with improved psychological well-being for children. But what's really interesting is that when you ask parents, particularly after a child has died, that actually some parents will experience decisional regret in terms of having continued disease-directed therapy right until the very end. So I want to challenge you that sometimes, although a family are really asking to continue therapy, that actually it's our responsibility to think, okay, if we don't think that's right for this child, then why is it not right in relation to what is important to them and what their goals are? Not the theoretical decision making about, well, this is probably not going to provide you, with another an extra 7 days or an extra, weeks. These things are less tangible for families. Talk about what's important to them, what their goals are, and whether that therapy is going to allow them to facilitate that. So Mary's primary goal then was to live as long and as well as possible. So actually that included a multimodal approach to her management. So she continued in imatinib. She had kind of neuropathic and somatic pain that was managed by a constellation of different medicines. She had some GI symptoms, she had some anxiety, and she had difficulty sleeping. So it required all of these things. And I guess the reason for using this slide is, do not underestimate the power of additional therapeutic and therapies and interventions. So things like non-pharmacological interventions like massage, Reiki, prayer, all of these things are really, really important to children and families. And actually things like massage, things like acupuncture, we have evidence to show that they are effective. So let's think about the language that disrupts or facilitates goals of care conversations. So I've given you the 7 questions, but what language actually do we use that helps to have those conversations? And what things do we say that potentially might not be helpful? So how do we introduce the concept of advanced care planning? So you've had the conversation, okay? You've asked those 7 questions. You've understood, okay, I know where this family are at the moment. They are up for a prolonged life. They're not bothered about suffering in the short term because they actually just want life extension, or one of the other buckets. So timing has got to be right, okay? It's got to be right for the family, but it's also got to be right for you. So if you've had a terrible day or you've been up all night on call, delaying that conversation is important, okay? I think when you have an initial conversation, it's really important that you don't try and rush things up front. It's not about having paperwork signed at the end of it. So sometimes for families, just raising the possibility of deterioration or raising the possibility of what might be ahead is enough. There are other families who will want to know absolutely everything up front, and they want to know what options are available to them. And it's important to have a little bit of an idea as to how you think that family might respond. So think about the conversation before you go to have it. Find ways of communicating and introducing these concepts that feel comfortable for you. So listen to other people and think about things that you've seen that work well and things that don't go well. I'm all about communication being natural, but I think it is helpful to have some phrases in your back pocket that you can go back to. Yeah, so I'm going to give you some of them at the end of this talk. Adapt to the situation. So every family is unique. Prepare, okay? So know your stuff before you have that conversation. You know, anticipate some of the questions they might ask and look into that. And be human. If you genuinely care for a child and want the best outcome for them, parents will see that and they're more likely to work with you. So these are the usual rules. We'll skip through this because you all know this about space, time, and body language. So practically, how do I start these conversations? So I might say, you know, we've got to know each other a bit, and I'm worried that all the things that we're currently doing are not actually really helping, or they may not be helping us. And we probably need to start thinking about what options and choices we have if your child continues to deteriorate and doesn't improve with treatment. I might say, look, we've actually talked about all the treatment options, but I think it's also really important that we talk about how we look after your little one if we don't get the outcome that we're hoping for. And is that something that you're able to start thinking about now? So give people permission as to whether they're ready to have that conversation or not. It might be that you refer to the condition. So I know that you're aware that children with ATRT, children, you know, are unlikely to survive into adulthood. Some families find it helpful to start thinking in advance about what may happen and how we should care for their child when they become unwell. Is that something you've thought about? And the reality is yes. And is it something that you think would be helpful to start thinking about now? I think it's important that sometimes when you ask those questions, parents say, no, we're not ready to talk about that. And I think that's actually okay. And what I would say to that is, okay, that's fine. I'm going to check in with you from time to time to see if it's something that you want to think about. So not parking it completely, but revisiting that. But I also give them a warning shot and say that there may come a time where we have to start thinking about these things, whether you're ready or not. And if we get to that point, I'm going to tell you. And actually, can I tell you, by having those conversations beforehand, it's much easier to then have that conversation when you actually need to. Very briefly, I think I want to touch on resuscitation because that is important. And I think the conversations that you have with families about resuscitation they're a big thing. They're a big deal for families, but they're a big deal for us. And I think often families don't have the same understanding as resuscitation as we do. And an example of that would be that families often think that going onto a ventilator is some sort of magic machine that you go on that and you get better. And actually, when you explain to a family that all that a ventilator does is buy us time to find something that we can fix the lungs, that we can make things better. But all it does is buy us time. And if the reason that you're going onto the ventilator at the outset, by putting onto the ventilator, I know that progressive tumour that's invading your brainstem is not going to get better, then actually the merit, the utility of ventilation in that situation is much, much, much less clear. And if you explain it in simple language to families in that sense, they understand it much better, rather than just having, do you want us to intubate and ventilate your child? It's helpful to explain why a child might deteriorate. Be prescriptive, explain why cardiac and respiratory resuscitation are different, okay? And I think that is really, really important. So when the heart stops, your child is dead. And that's important for the family to hear. Situations where resuscitation might be helpful and those where it might not. So I just want you to really think that when you're having resuscitation conversations, actually it is really think about breaking that down in a way that perhaps we're not necessarily trained to do. Okay, so that just summarises what we've talked about. So how we might manage significant deteriorations, what it might look like, what we would recommend if your child stops breathing, what we would recommend if your child's heart stops. The views of parents will change over time, and most parents actually don't want to sign a SEPADM form, months in advance. They want to keep their options open as long as possible, but that is not an excuse to not have those conversations. It's much less about having the form and about actually having the conversations and then carefully documenting them. Okay, so what are some of the words and phrases that send unintended messages or sort of communication faux pas? So I'm going to just leave this up there for a few seconds, just for you to think about some of the words. We want our language as much as possible to empower families about things that we are going to do, things that we are going to actively do. You can actively manage symptoms at the end of life, rather than focusing on things that we're not going to do, things that are not appropriate. You stay away from judgmental language, okay? Stay away from statements like nothing can be done. You know, we can't do anything now. We need to just do nothing here. That language fills parents with dread. I'm going to skip these slides. If you make a mistake, say you're sorry, okay? We're not perfect, we're human beings. And I've certainly had communication with families where it has not gone the way I had intended, or I've said something and I just say, I'm really sorry, that's come out the complete wrong way. That wasn't how I meant that to sound. Do you mind if I start again? And most families are very forgiving if you have the humility to accept when you are wrong. So summarise your recommendations, particularly when we're talking about resuscitation. Actually, this is what we've talked about, and this is what I've heard from you. And what I'm going to do is I'm going to go away and I'm going to write that down, and I'm going to come back to you and go through it with you and make sure that actually what I've heard is definitely right. There's often times where we have conversations where what we hear is not necessarily what a family has understood. So very, very finally, I want to leave with you some other things for your toolkit. So how do we deal with situations where we don't get agreement? So first of all, I think you need to explore why parents don't agree with you, and explore why you hold your view. Is your view correct? And a good way to think about that is to consult with your colleagues. Now, that might be colleagues in your own centre, or it might be seeking a second opinion, to ask other people to think about if they were in this situation, or to look at this situation, what would they do? Often it can be helpful for families to talk to people that they trust. So friends, relatives, it might be a faith group, it might be another team. And actually, sometimes talking to a team who's not directly involved in the care, so not your primary team, it can be a palliative care team, it might be an intensive care team, can be helpful for families to be able to say things that they don't feel comfortable to say to their primary team because they're frightened that will influence care. Sometimes we don't get an agreement and you need an interim plan. So we're going to do some basic life support. We're going to call the parents in, we're going to call the consultant in, but here's what we're not going to do in that situation. So you need clear parameters that you're not going to end up escalating to intensive care. I just want to touch upon that if you really genuinely if you reach an impasse and you're not able to get agreement, that actually now courts will probably not hear cases until we've gone through professional mediation. So that might be internal mediation within the hospital, but increasingly we're using external agencies for that. And so that's really important to be aware of that. And it's something that as a trainee, I was not really aware of. I've now been trained in mediation, but that's something that you might want to think about, some professional mediation training. And then finally, to discuss with the legal team. Now, I want to say to you that when you hear that thing, you often think, oh, this is going to be very adversarial. Can I tell you that actually, in my experience, saying to a family, look, we clearly have your little one's best interest at heart, and that's what we both want. But at the moment, we can't reach an agreement because we fundamentally think different about this situation. And so what can be really helpful in this situation is to ask someone wiser than us, someone who is not directly involved in the care and someone who has an overview. And so that's quite often why we involve our legal teams within the hospital or potentially out with the hospital. Now, I'm not saying that always works, but actually that does open a conversation, and most families actually will recognise, okay, they're happy to have second opinions, they're happy for you to go externally to ask about advice. Okay, so finally, what other things can I put in your toolkit for managing parental expectations? Because often at the end of this, people say, well, this is all very well and good, but the reality is we often deal with people who we feel their expectations of what we're able to do or what a treatment is able to do is out with of what we personally think or what we professionally think. So I want to teach you about wishing, worrying and wondering. So this was produced by the Canadian Hospice Association for having conversations with people with serious illness. So I want you to remember these three words. So wishing is your ability as a clinician to align yourself with what families want and what families are hopeful for. So that might be a family of a child who has got a progressive GBM saying, Johnny, I want a miracle. I want my child to survive and I want this tumour to disappear. And I might say to that, do you know what? I completely understand, and I wish for that too. But the worry part of that, so that's now my ability as a clinician to provide my honest, my clinical experience. So I wish for that too, but I'm really worried that actually things are progressing, and we can see that by the scans, we can see that by symptoms. Despite all we are doing, the tumour is progressing, and time is likely to be short. And I wonder, this is your ability to make a subtle recommendation, and I wonder actually if now is the time that we're not trying to take away your hope, but actually we need to now seriously think about, if we're in this situation, what is important to you then? So by you wishing, you're aligning. Worrying allows you that permission to be honest, to use your clinical integrity, which is so, so important, and you mustn't shy away from that. That's what we get paid for. And then to wonder, you know, allows this subtle recommendation without you taking an autocratic approach to telling families what they should and shouldn't do. Finally, when you're dealing with emotion, so this is an acronym NURSE that's quite helpful, so name it. I can see that you're upset. I can see that you're very frustrated. The only thing that I'd be very careful identifying emotion is with anger. So sometimes if you say to a family, I can see that you're angry, that actually does the opposite of what you're trying to achieve, and it makes them even more angry. You then want to use, so the you part of that is understanding. So I can't imagine what this must be like for you. Now note that is I can't imagine, not I can imagine, because the reality is that even if you have a child with exactly the same condition and exactly the same, you know, clinical position, you don't fully understand what another family is going through, because we are all individuals. The way that we deal with, you know, decision making in families is very different. The R is about respecting. So acknowledge their love for their child. It's clear that you love your child. You know, I can see that the reason that you're angry, that you're upset, is because you desperately want what is right for your child. The S stands for support. So I'm going to walk with you through these difficult times. So I often say that to families, look, I cannot give you what your heart's desire is. But what I can give you is that my word that I am going to walk with you through the next part of the journey. And if that journey is difficult, then I'm going to be involved lots. If that journey is not as difficult as we anticipated, I'm going to be there when you need me. And explore, you know, I think a big part of my palliative care training was be inquisitive, get to know families, see if you don't understand something, ask them, look, can I just check, you believe this really firmly, where does that come from? If it's a religious belief, tell me more about your religious belief. What do you believe? Show interest. So what I want you to think about today, we've talked about lots of things. I want you to think about what's your one thing, what's the thing that you're going to take away from my talk today? Is it the practical application of the goals of care conversation? Is it that you're going to try, next time you reach an impasse with families, you're going to try and wish, worry, wonder? Think about that. And I want to leave you with one word, so authenticity. That actually, if you are authentic in your communication, you will organically grow good relationships with families. So be honest, be open with people. And actually, I would challenge you that do not be the gatekeeper for a family. Don't try and protect them from pain and suffering, because the reality is we often can't do that. We are not causing that as professionals. They are facing really difficult times as families because of a diagnosis, because of an illness, and we can't always take that away with therapy. And so actually we must learn to be comfortable to sit in that space and be able to utilize our other skills to be able to support families and to allow them to be resilient longer term. So that's the end of my talk. It would be good, I guess, to open up the floor to see if there's any specific questions that you guys might have, or anything that you want to touch upon that we've already talked about. Daniel Houghton, it's lovely to see you.
Hey Johnny, how are you doing?
I'm good, pal, I'm good. It's nice to see you.
I put my question in the chat, but I can speak it out loud.
Sorry, so, let me have a wee look here. So you said brilliant to practice these conversations. I wonder where you might bring the children to these conversations. Okay, and how do the family judge that? Really, really good question, Dan. So I think people often, we often think about actually how do we communicate with children? And I think probably that mainly comes when we talk about adolescence, but I guess the challenge is that often that can come much, much earlier on. So I guess the way that I would approach that is, first of all, by getting to know how a family communicate with their child. So how do you normally communicate with your child? are you a family that really openly communicates? So from the point of diagnosis, how much have you shared with your child? Do you know what I mean? How have you talked about it? What language have you used? You know, how have you deferred to cancer? How have you deferred to chemotherapy? And try to utilise those words, the individual words that they use and the way that they communicate. I guess sometimes, Dan, I would ask outright, I would say, look, we're entering a period of time where clearly the disease is progressing and, you know, we're now not going to be, our goal of care has changed. So, for example, you're not going to be in hospital as much. That might seem strange to your child because they've been used to being here. They might question what the next steps are. Have you thought about how you might handle those questions? Have they asked about those things? And actually, quite often parents will say, well, actually, I'm really worried about that situation. And what we know from evidence is that actually it's about having age-appropriate conversations and allowing children permission. So children are very good at trying to protect their parents. So it's about really offering them an opportunity to say, look, I wonder if you get any worries. So, you know, you're thinking, you've mentioned that you're not going to hospital as much. Are you worried about that? What are you thinking about that? And offering them opportunities to speak out. Often, to be honest, Dan, the people to do that are not necessarily their parents, but other people who they trust, and they can start to facilitate some of those conversations for families. I'll tell you, the brain tumor charity actually provides really good guidance for families. The cardinal questions do work for children, so I would use them for children, and you know, I think they're really helpful. I've got a kid in ITU at the moment who I've used them on, and really just to get to know them. And I'll tell you, it opens up conversation with them, and you get to learn in a roundabout way, sometimes an indirect way, what's important to them without asking, you know, outright questions. Do you know what I mean, that might frighten them? The one thing that I would say to you is just be really careful that sometimes when children ask questions, I've learned this from experience, I now will ask, why are you asking me that? Because sometimes the question sounds to us as adults like fairly binary, like, am I going to die? And what they don't want is for you to say yes or no. Actually, their question is different from that. So I now say, well, why are you asking me that? And it gives you an opportunity to have a much bigger conversation. I don't know if anyone else has got any other questions. I guess if you don't have any other questions, what I would say to you is that you do need to have opportunities to practice these conversations. And I think the best way to do it initially probably is sitting in with people who have those conversations. But actually, I guess if you have a good relationship with the teams that you're working with, there are times where you can say, look, can I lead in the first part of this conversation? Do you know what I mean? Can I start to initiate these conversations? And then can you step in if I am feeling uncomfortable or you feel that I'm wandering off? Because actually it's only through practice that you're going to learn to do that and feel comfortable with doing it. So although it feels intimidating and it feels nerve-wracking to do, it is really important to be able to have those opportunities. The other thing I would say to you is try to get on advanced communication skills training courses. So EC4H is a course that runs an adult palliative care course, but it's a really good course for giving guidance about difficult conversations. So I would thoroughly recommend that. But there are other courses available too. But I would strongly encourage that.
Thank you very much, Dr. Downie, for that very interesting bend on this very difficult topic, as you may know from our work up here. So we recorded this session. We'll hopefully make this available for everybody so they can go back and see. And if you have any questions at any point, we can make arrangements to relay the questions to you if you've got time to answer them as well.
Yeah, okay. I'd be delighted to do that. That's great. Well, it was a pleasure to be with you this afternoon, guys. It was nice to see you all, and I hope you have a good evening.
That's great. Thanks everybody for attending.
Bye, guys. Bye-bye.